And so let's take a minute now to look at some typical patient scenarios that can come up. So case number 3, a patient in the middle of the road, if you will. So this is a 65-year-old man with a 40-pack-year tobacco history, presents to clinic with chief complaint of increased dyspnea on exertion, cough, and lower extremity edema. He noticed the onset of these symptoms about 6 months ago, but they are now rapidly progressing. His oxygen requirements have again also increased over this time frame. Really, his wife, again, the purveyor of truth, is frequently the spouse in the room. Really, his activity has decreased substantially over the last 2 years. So while he relates this as a 6-month event, if pushed, he's been dropping off for some time. Often this is attributed to getting older, deconditioning, etc. His edema, however, is newer, and then really he's now noticing some lightheadedness with exertion. Vitals, blood pressure a little bit on the soft side, but okay. He's tachycardic at rest, and then on 5 liters per minute, satting 92%. So a pretty big oxygen requirement, presumably a pretty large AA gradient in this scenario. Really other findings, we now have a prominent second heart sound, a louder left upper sternal border systolic ejection murmur, and now some elevation of jugular venous distension, again with prominent V waves. His CT scan showing rails in the bilateral bases, really halfway up the thorax, with decreased breath sounds at the apices. And his extremity is showing us pretty significant edema, 2+ without clubbing. Basic metabolic, again, really not much here pulling us in. And again, here's another patient showing us polycythemia and white count and platelet count okay. So here we look at his physiology, initially with PFT data. And we can see from his flow volume loop this high early peaking spirometry, but also then some later tapering, speaking for both restriction, but perhaps also some airflow limitation. When we look to his spirometry, his FVC and FEV1, we see a decline in both, but interestingly, a decrease in FE1 to FVC ratio, more consistent with an obstructive disease state. But with that, decreased lung volumes, which really now point us perhaps in a mixed direction, that is mixed obstruction and restriction. Importantly here, and important to look at this in all our PFTs when we're considering pulmonary vascular disease, is DLCO is quite low and really only minimally corrects for alveolar volume. So 47% correcting up to 54%, really sort of invoking, or should invoke in your mind, the potential for pulmonary vascular disease on top of his parenchymal lung disease. And here we see a coronal image of his CT scan, and we see a couple of different things. We see some sort of more emphysematous changes in the apices with more parenchymal restrictive changes in the bases, again with some septal thickening, some fibrosis, appearance of fibrosis, and traction bronchiectasis. So a nice example of traction bronchiectasis in his base here. So again, a pattern with sort of, again, mixed, going with his physiology of obstructive and restrictive. When we look at his echo here at this point, we see, again, significant RV dilatation with some right atrial dilatation as well, moving to the severe range, and then also significant RV dysfunction with a low TAM and TAPSE as we look to his free wall motion here at this point. So severe RV dilatation leaves moderate dysfunction in an RVSP. I'll just tell you here at this point, estimated at 70 millimeters of mercury. Again, essential when considering treatment. I hope one important point, again, I've made multiple times, is that if we're thinking about therapy in this patient group, we need invasive hemodynamics to help us work out what we're doing. This lays against the parenchymal imaging and then the physiology by PFTs. It's an essential aspect of the assessment. Here we see a slight elevation in the right atrial pressure, okay, wedge pressure, so left side flow pressures are okay, and then at least moderate pulmonary hypertension for the parenchymal lung disease group, moving really sort of more into the severe range if we think about it, because normally when we look at parenchymal lung associated pH, the pressure elevation is really not this high, on up to 40 millimeters of mercury. A slight decrease in its cardiac index and an elevation of PVR to 6.8 Wood units. An oxygen challenge, so assessment of what component hypoxia is playing, at least here acutely, and we see some decrement, which again is typical. Mean PA pressure dropped to 37 from 40. Output and index are about the same. PVR decreased slightly. And then adding an acute vasodilator, we see really no significant change from the oxygen that was administered. Mean PA pressure, if anything, actually went up 38 millimeters of mercury. Output and index about the same. PVR at around 6 Wood units. So really no large change either from oxygen or from adding a acute pulmonary artery vasodilator. And so this really emphasizes an entity that can present with essentially, just as this man did, very severe both parenchymal lung disease as well as pulmonary vascular disease. And this was an interesting study from some time ago now, 2005, by Cath et al., really showing that when patients with this combined pulmonary fibrosis and emphysema, patients are looked at, and they in fact develop pulmonary hypertension, which they have a tendency to do at significantly higher amounts or higher levels of pressure elevation than we see in other parenchymal forms of lung disease, their mortality increases significantly in relation to the pulmonary hypertension. And so this is a group that I personally will look at carefully in terms of treatment for their pulmonary hypertension, that is their group 1 form of PH, but also recognizing that this can be a real challenge for all the reasons that we mentioned before, because frequently, again, they have this combination of both ILD and emphysema, and it is very easy to clinically make these patients worse from a hypoxemic standpoint by adding pulmonary artery vasodilators. There's just not a lot of lung that's functioning appropriately in this patient group. And so this can be really a big challenge. However, this is a patient that tends to not do well at all from a pulmonary vascular standpoint, and their RV can be very severely affected. So what would you do next to this patient? Increases O2 to 8 liters per minute. That's, if we're assessing he's hypoxemic, he presented at 6 liters. Perhaps we do need to assess that some more. Refer for lung volume reduction surgery to upper lobe emphysema noted on CT scan. That is, well, we'll talk about that momentarily. Refer to a pulmonary hypertension center for excellence or consideration of a trial of PAH therapy. And this may be an area where one might consider some of the recent data that came out of the INCREASE study. This is certainly data that I won't delve into further at this point, but if we turn to Dr. Steve Nathan's talk, really in this same series, he'll delve into this more, and it's kind of an exciting area in the treatment of parenchymal lung disease associated or CLD associated PAH. And so this is what I would select here, though honestly, it's never a bad idea turning your oxygen up if your sats are up. So I might, if you put A in there, wanted to do AC, I'm okay with that. I would not pursue lung volume reduction surgery. I think his, in this scenario, really he wouldn't fit the classic paradigm for what we look for in that scenario, and his operative risk would be quite high. So let's turn now, sort of our waning minutes here, for a treatment algorithm for group 3 ILD-associated PH. Really, and this kind of gets at a way of thinking at it, usually, again, in sort of outlining how we as clinicians, you as a clinician, would really approach most patients. That is there a suspicion for this disease state by the history, by your exam? Is there support of what you're thinking through non-invasive screening mechanisms? We need to confirm it. I've said it 20 times. I'll say it 21 times. Really, the right heart cath is essential in the management or assessment of these patients. And then we need to stratify. Does this patient you're looking at with both parenchymal lung disease and PH, really, which phenotype are they fitting more into? Is this more a group 1, or is this really kind of more typical of group 3? And these are the ways to think about this. So limited chronic lung disease versus more severe chronic lung disease, looking again at their RV and their hemodynamics. And then, if we're fitting more into group 1, then going down a treatment algorithm for PAH, but with careful reassessment, as we always do, but really paying very close attention to what's happening from an oxygenation standpoint, from a physiologic standpoint. And then group 3, then, I think these ones can be very difficult. Again, we've historically have lacked good data to treat this patient population. We certainly know we can make them worse, which is, again, certainly none of our goals. Do no harm paradigm needs to rise above all else. But there may be subgroups within there that we want to launch into treatment. And I think the more experience one has in this area, the better off you are in terms of trying to make this assessment. So I think reaching out to centers of excellence to really help tease out, is this a patient one might consideration therapy? And, realizing that if we do go down a trial of this, it has to be assessed very carefully with a very frank conversation with the patient, that there is possibility that we may drop your oxygen, but we're really looking to see how much your pulmonary vascular disease and RV dysfunction is contributing to your current therapies. And exciting areas, as I've mentioned now moving forward, is that we are now perhaps moving into the area of evidence to support treating at least some of these patients, that is PH-ILD, though again I think we have to go into that cautiously and carefully and watching to pick the correct patients from this scenario. So this patient was referred to a PH specialty center. PH therapy of inhaled treprostinil was in fact initiated and was slowly up titrated with close follow-up. There was symptomatic improvement over the first 6 months of treatment with improved walk distance, improved functional class. There was a cough, and in particular with these inhaled prostanoids, cough is a typical manifestation, and that can be very distressing to someone who already has cough, but in this particular case, it was tolerated okay. And then again, the titration, important to be slow and careful with this, realizing that you may not get up to max treatment due to potential side effects. So summary and final thoughts. ILD and pulmonary hypertension frequently occur together. This is not an unusual scenario in the real world. They get excluded a lot of times from our clinical trials, other than what we're launching into now, which is the more of the group 3 specific clinical trials. But our early studies in PAH, these patients were left out. Early studies, as I've mentioned, have really not shown benefit, though again, excitingly, we may be moving into a new era here. It's important to distinguish and quantify the impact of each disease component on the patient, really trying to decide where is the appropriate therapy, how much is the ILD driving it, how much is the pulmonary vascular disease driving the patient's symptoms. The impact on hemodynamics and severity of chronic lung disease can help us decide therapy, and then treatment paradigms for ILD-PH are evolving, so we may have new therapeutic paradigms here in the near future, which would really usher in a new era when I think many of us have been working towards and are excited to see, as this is a group of patients that are certainly common and ones that we would like to treat if we can find the correct medications and the correct patient population. With that, I will stop. I want to thank you for your time and attention.